Hi, and welcome back to this second video in the 11th lecture of Covidenomics. In the first video of this lecture, we looked at how different policies, different interventions can be used as either substitutes or to form a complementary package to deal with particularly the second wave of coronavirus infections. And we noted that there was pretty good evidence that simple lockdowns, which have a high economic cost, are neither necessary nor sufficient to deal with that second wave. And we looked at the arguments that suggested that a more nuanced approach, using lots of non-economic, non-pharmaceutical interventions. Policies like mask wearing, social distancing, and a regime of testing, tracing and quarantining those who are positive with the virus can form a package that limits the economic harm from the virus while still keeping the number of deaths down, particularly if tied in with, for example, making sure that there is a high degree of protection around aged care facilities, and perhaps limiting some of the economic activities of the most likely places to spread the virus. For example, indoor sports, indoor restaurants, bars, clubs, and gymnasiums. In this video, we're really going to concentrate in on the test part of test, trace, and quarantine. What sort of testing regime do we need? How do we deal with having different types of tests with different degrees of accuracy? Should we only use the most accurate test? Or is there a trade-off between accuracy, speed of results, and the cost of a test? I'm going to refer to a number of articles in this particular video, but here are the two main ones that I'm going to be drawing from: Bergstrom and Lee, Frequency and Accuracy of Proactive Testing for COVID-19. That's from September 6 this year, and you can grab that online. And this article by Joshua Gans from Covidenomics, Test Sensitivity for Infection versus Infectiousness of SARS-CoV-2, which comes from the 4th of September this year. But first off, let's think about what types of tests we have available for people who are currently infected with SARS-CoV-2. A nice piece that I'm going to use to help us here is by Maureen Ferran from the Conversation in May 6th of this year. Coronavirus tests are pretty accurate but far from perfect. Professor Ferran notes that there's basically two categories of testing. The first one is an RNA-based test. Formally, it detects genetic material from the virus in an individual, and it's sometimes called PCR test or RT-PCR. PCR stands for polymerase chain reaction test, and sometimes called the reverse transcription polymerase chain reaction test. I'm going to call it the PCR test because that's my limited biology. The second set of tests are antigen or antibody tests. Essentially what these tests are doing is trying to see if your body has reacted to the presence of the virus. And it can do that, for example, by starting to produce antibodies to the coronavirus. And you can test a person to see whether those antibodies are present, for example, through a blood test, or to see if the antigens which lead to the production of antibodies are present, for example, in a saliva test. Given these two types of tests, an obvious thing that we want to ask is, well, how accurate are they? There's two measures of accuracy that are used in the medical literature. The first is sensitivity. This looks at how often the test correctly identifies a person who is actually infected with the virus. So, for example, if a test is 90% sensitive, it will correctly identify 90% of people who are infected. The second measure of accuracy is specificity. So does the test correctly identify as not infected a person who is in fact not infected? For example, if a test is 90% specific, it will correctly identify 90% of people who are not infected. So we can think of sensitivity as being how often does the test give a true positive, and specificity is how often does the test give a true negative. To help explain what these mean, I'm going to draw on a really nice little article by Robert Trevathan, Sensitivity, Specificity and Predictive Values, which comes from 2017. Robert provides this nice little table to help us think about sensitivity and specificity. So on the horizontal axis, we have the status of the person, so we can think of this as simply, is the person infected or is the person not infected for our purposes. And going vertically, we have the results from the test. Are the results positive or are the results negative? So if a person has the condition and they're positive, they test positive, then that's a true positive result from the test. If a person has the condition but tests negative, then you're getting a false negative. You've got a test result of negative when the person should have come out positive. If the person doesn't have the condition, if they're not infected, and the test result comes out negative, of course that's a true negative. But if they have the condition and it comes out positive, then you've got a false positive. You can think of dividing up our population of, say, 100 people into these different categories. So, of the 100 people, how many will be in this top left-hand box? That's the number A. How many will be in the bottom left box? That's the number C. Top right, that's the number B. And the bottom right, that's the number D. And obviously A, B, C and D need to add up to 100, and obviously we're going to be calling them percentages. And sensitivity comes from these two numbers A and C, while specificity comes from these two numbers B and D. How? Well, this is just a simple application of Bayes' rule. So sensitivity is going to be A over A plus C. Specificity is going to be D over B plus D. And because I've set my population as 100, we've already multiplied by 100. How do we see this? Well, remember that sensitivity is looking at whether we get a positive result from the test, given that the person is actually infected. So it's just going to be the probability of getting the true positive over the probability that the person is infected, A over A plus C. While specificity is the probability of a true negative, so given the person is not infected, we want the test result to come up with a negative, so it's going to be the test gives a negative divided by the share of a population that doesn't have the condition, D over B plus D. From your course in statistics, you might have heard the term false positives and false negatives. We can also get that straight off this diagram. So for example, if we've got a positive test result, then the probability of a false positive is just going to be B divided by A plus B, and the probability of a false negative is going to be C over C plus D. Given that you've got a negative result, what is the probability that it's in fact a false negative? Or these can be given the other way around. The positive predictive value of a test, which is just 1 minus the probability of a false positive, and the negative predictive value, which is just 1 minus the probability of a false negative. Let's use some numbers to see how this works. So we've got our population of 100 people, and we're going to say that 5 people on average out of 100 randomly chosen people will have the condition. So that's going to be this left-hand column here. And 95 out of 100 people on average will not have the condition. That's the right-hand column. On average, out of those who have the condition, if they take the test, 4.5 are going to come up positive and 0.5 are going to come up negative. Conversely, if they don't have a condition and they take the test, 0.95 are going to come up as a false positive, 94.05 will come up correctly as a negative. Now, if we do that, then we can work out the sensitivity and specificity of this particular test. The sensitivity, remember, is just A over A plus C, or 4.5, divided by 5, or in other words, 0.9, or 90%. The specificity is going to be given by D divided by D plus B, and in this example, that comes out at 0.9 or 99%. The chance that a person who is tested positive is in fact a false positive for this particular test is going to be 0.95 divided by 4.5 plus 0.95. And if you grab out your calculator, you'll see that that comes to 17%. So with this test in this population group, the chance of a false positive is around 17%. And if you remember that the probability of a likelihood of getting a false negative is, well, someone's tested negative, but it's a false result, so it's going to be 0.5 divided by 94.05 plus 0.5, which is pretty close to 0.5%, as the probability that the test will give a false negative given this population. The reason why the medical profession use this idea of sensitivity and specificity is because they don't depend on the population breakdown between those that are infected and are not infected. It's simply a function of the test itself. Whereas things like positive and negative predictive power, or their converse, false positives and false negatives, depend on the distribution of the virus across the population. Whilst I've used specific numbers here, so we come up with a really well-defined sensitivity and specificity, and these are the numbers that Gans uses in his article, things unfortunately aren't that easy. And simply to come up and say, well, what are A, C, B and D in reality? What are the sensitivity and the specificity of the test? That is actually quite a difficult problem. If we look at the PCR test, for example, in clinical settings, it's extremely sensitive. So it gets close to 100% in terms of its sensitivity, and it's got a very high specificity, higher than 95%. However, that's in a clinical setting. In real-world settings, where there's issues about, well, that swab going up your nose or that swab going into the throat, how the sample is treated, then the levels of sensitivity and specificity can vary widely. So when we're looking at these tests being used in the real world, it's actually quite difficult to come up with specific numbers here. It's not the same as in a clinical setting where these can be quite high. Regardless, however, of how you cut it, the general consensus is that these RNA-based tests, these PCR tests, are the gold standard of testing for SARS-CoV-2. They tend to be more accurate than the alternative antigen and antibody tests. Yes, there is a variation here, depending on how the test is exactly done, and the difference between in the field and in the lab. But overall, these are going to be the accurate test compared to the variety of alternatives that are out there. So, the question is, should we rely on these PCR tests? Well, the economics pretty strongly says the answer is no. But there are good reasons to use these antigen tests or antibody tests either with the PCR test, or in actually the case of Joshua Gans' paper, he argues that the antigen and antibody tests are in fact better at answering the appropriate question of whether a person is infectious than the PCR tests. Let's see why. I've just worked out how long I've spent so far on this video. I'm actually going to call it quits there, and we'll have another video answering the question of why. So talk to you next time.